Hi guys, welcome back. So after discussing BLS, that is basic life support in detail, in which we figured out that even a non-medical professional can provide the BLS and save life whenever needed following cardiac arrest. In this particular lecture, we will discuss advanced cardiac life support, which has to be provided only by medical professionals as per AHA guidelines. In this, we will mainly study four things, that is ventricular fibrillation, ventricular tachycardia, asystole, and pulseless electrical activity. And in this particular lecture, we will also study about ghosts. We will also talk about ghost rhythms. We will also discuss defibrillators in detail. So let's start this lecture. Right, so let's start our discussion on ACLS, that is Advanced Cardiac Life Support, which has to be provided by medical professionals, particularly in case of in-hospital cardiac arrest. Whereas in case of BLS, we studied that whenever there is out of hospital cardiac arrest, even non-medical professionals can provide basic life support. But these non-medical professionals cannot make differential diagnosis. They can figure out whether there is cardiac arrest or not, and following cardiac arrest, they can provide high quality CPR. And if there is AED, that is automated external defibrillator available, they can use this device. And in case there is shockable rhythm, this AED will provide shock and patient might improve. And following this basic resuscitation, that is BLS, patient can be transported to hospital, and in hospital patient can be provided advanced cardiac life support. So in case of BLS, you don't make differential diagnosis. You just assume that patient is having cardiac arrest, and then you do your job, followed by transfer of this patient to a capable hospital. Whereas in case of advanced cardiac life support, that is ACLS, doctor will analyze the rhythm of patient with help of ECG, and then if there is shockable rhythm, doctor will provide the shock, that is doctor will defibrillate this patient. And in case there is no shockable rhythm, doctor will continue with the CPR, and he can also use epinephrine in between. Okay, so in case of ACLS, you have to make the differential diagnosis, and in this differential diagnosis mainly you have ventricular tachycardia, particularly pulseless ventricular tachycardia, ventricular fibrillation, asystole, and then you have a condition by the name of pulseless electrical activity, in which electrical activity can be even normal, but it will not be associated with mechanical activity. Therefore, it is also known as ghost rhythm. There is electrical activity, but without any mechanical activity, without any pulse. Right? These will be close differentials in hospital cardiac arrest scenarios. Okay, and here use of defibrillator will be very important, along with another life-saving drug, that is your epinephrine, that is your adrenaline. Okay, too simple to understand. So we will be using this defibrillator and epinephrine in case of ACLS. So these will be two main components of ACLS, along with continuation of high quality CPR, that is cardiopulmonary resuscitation. Now let's try to understand. This is your automated external defibrillator, available at cinema halls, airports, railway stations, etc. in case a person suffers from out of hospital cardiac arrest. As a part of BLS, you can provide high quality CPR, and you can use this automated external defibrillator. In case of shockable rhythm, this machine will decide whether shock has to be given or not. Okay, whereas in case of non-shockable rhythm, this machine will not provide any shock, and you have to continue with CPR, and then you can transport this patient to a capable hospital where ACLS can be provided, that is advanced cardiac life support. Okay, so this AED will decide whether shock has to be given or not, whether there is presence of shockable rhythm, that is ventricular fibrillation or pulseless ventricular tachycardia. Whereas in case of ACLS, you will be using manual defibrillators. These manual defibrillators will be operated by doctor, and in case there is shockable rhythm, doctor will defibrillate this patient, that is doctor will provide shock. Okay, now try to understand. Here you have various components of BLS we have already studied. In BLS, we did study that first and foremost, you have to verify the scene safety, that is ensuring scene safety, and then you have to call for help, and then you have to provide high quality CPR in the ratio of 30:2, that is 30 chest compressions followed by 2 rescue breaths, and then you have to apply your automated external defibrillator. In case it is a shockable rhythm, AED will provide shock. In case it is not shockable rhythm, AED will not provide shock. You have to continue with the CPR, and then you have to shift this patient to a capable hospital. So this is your BLS in which you provide quality CPR, and you can use automated external defibrillator, and then you have to shift this patient to hospital. And now in this hospital, this patient can be provided advanced cardiac life support. Okay, too simple to understand. Right, now let's discuss ACLS, that is Advanced Cardiac Life Support for adults following cardiac arrest in case of in-hospital cardiac arrest. Try to understand, this particular algorithm is for adults following in-hospital cardiac arrest. Try to appreciate few things. As soon as you figure out someone is having cardiac arrest, start with high quality CPR. Also provide oxygen and attach monitor to this patient. These monitors will project the ECG tracings, and by these ECG tracings you can figure out whether this person is having ventricular tachycardia, ventricular fibrillation, or there is pulseless electrical activity, or there is asystole. Now you can proceed accordingly. In case of ventricular fibrillation or pulseless ventricular tachycardia, you have to provide shock to this patient and you have to continue with the CPR. And in case it is shock resistant cardiac arrest, you have to provide epinephrine. Okay. Now, if it is a non-shockable rhythm, for example, asystole or pulseless electrical activity, in these cases you have to provide epinephrine as soon as possible and you have to continue with the CPR. Try to understand. In case of ACLS following cardiac arrest, you start CPR and you have to attach the monitor, and this monitor will provide you ECG tracings. So in this ECG you can figure out whether it is pulseless ventricular tachycardia or ventricular fibrillation. On the other hand, you have pulseless electrical activity or asystole. Prognosis of this part is better as compared to pulseless electrical activity or asystole. Now you have manual defibrillator and it is your decision whether to provide shock to this patient or not. And these are your shockable rhythms. So in this case, doctor will provide shock to these patients, and following shock, heart rhythm will be reset and this might help patient improve. Okay. Whereas these are non-shockable rhythms. You don't have to shock these patients. Okay. Now try to understand. Here you have to immediately provide shock. Here you have to immediately provide epinephrine. Following epinephrine administration, these rhythms can change into shockable rhythms. And I have already told you guys that prognosis of shockable rhythms is better as compared to non-shockable rhythms. So try to understand. In case of shockable rhythms, that is pulseless ventricular tachycardia or ventricular fibrillation, we will discuss ECG findings in these cases. You have to start with CPR and provide shock as soon as possible, and then you have to continue the CPR and meanwhile also provide IV access or intraosseous access to this patient. Suppose the rhythm is still abnormal, you have to continue with the CPR and you have to again provide shock to this patient. Now again continue CPR, but now also provide epinephrine. See, in case of ventricular fibrillation or ventricular tachycardia, you have to provide shock first, followed by CPR and epinephrine. Whereas in case of non-shockable rhythms, for example, asystole or pulseless electrical activity, first epinephrine has to be given and CPR should be continued. And in case you kept on providing shock and after 3 shocks you realize that this patient is not going to improve, it means that it is shock resistant ventricular fibrillation or ventricular tachycardia. Then you have to provide antiarrhythmic drugs, and antiarrhythmic drug of choice here is Amiodarone. It is very broad spectrum antiarrhythmic drug, and second choice of drug will be lidocaine. Okay. So in case of pulseless electrical activity and asystole, you have to start CPR and provide epinephrine as soon as possible. Whereas in case of ventricular fibrillation and pulseless ventricular tachycardia, you have to provide CPR and shock as soon as possible. And in case it is shock resistant ventricular fibrillation or ventricular tachycardia, you have to provide anti-arrhythmic drugs, that is your amiodarone or lidocaine. Okay. Right, now let's discuss ACLS, that is Advanced Cardiac Life Support, in detail. Suppose someone suffers from cardiac arrest in a hospital, that is known as in-hospital cardiac arrest. And here you have to provide advanced cardiac life support. You simply start with CPR and then you provide oxygen to this patient and you attach monitors, and these monitors will portray ECG tracings on the monitor, and these ACG tracings will help you decide whether this person is having ventricular fibrillation, that is known as VFib, or this person is having pulseless ventricular tachycardia, that is PVT. Now try to understand. In these ECG tracings, you can figure out whether this patient is having pulseless ventricular tachycardia or ventricular fibrillation, or this person is having pulseless electrical activity or asystole. See, let's study ECG tracings in all these cases. In cases of pulseless ventricular tachycardia, take example of monomorphic ventricular tachycardia. heart rate will be in the range of 100 to 350. And in ECG you will have, particularly in monomorphic ventricular tachycardia, ECG tracing something like that, there will be broad QRS complex and heart rate will be mostly regular, but patient will be not having any pulse. This is pulseless ventricular tachycardia, and immediately you have to provide shock to this patient. Whereas in case of ventricular fibrillation, there will be tracing something like that, will very ill-defined electrical activity, and that too very fast. In these cases, you have to provide defibrillation to this patient. That is, these are shockable rhythms. Whereas in case of pulseless electrical activity, try to understand, this is also known as ghost rhythm, there will be normal electrical activity. There can be normal electrical activity, or there can be electrical activity other than this pulseless ventricular tachycardia or ventricular fibrillation. Take example of normal electrical activity. But this patient is not having any type of mechanical activity. That is, there is no contraction or relaxation of heart, resulting into absence of pulse, and therefore this patient has collapsed. See, purpose of defibrillator is to correct the rhythm of heart, but here you have already right rhythm, so there is no use of defibrillator. CPR provides mechanical support to heart. In this case, because mechanical activity is missing, therefore your treatment of choice should be CPR. Whereas in case of asystole, there is no electrical activity at all. This is your pulseless electrical activity, and this is your asystole. In case of asystole, there is no electrical activity, so there is no point of correcting the rhythm. This defibrillator corrects abnormal rhythm. But if there is no abnormal rhythm, how this defibrillator is going to correct it? Therefore, in these two cases, you will mainly do CPR, plus you have to provide epinephrine as soon as possible. Whereas in case of shockable rhythm, primary treatment will be CPR plus defibrillation of the patient. Okay, right. In ACLS, you can encounter two situations, whether you can have shockable rhythms or there can be non-shockable rhythm. If you find shockable rhythm, you have to immediately provide shock. That is, you have to immediately defibrillate this patient. If you have non-shockable rhythm, you cannot provide shock. You have to continue with CPR, and you can provide epinephrine earliest. Try to understand. These are shockable rhythm, therefore you will provide 200 joules of shock. Whereas these are non-shockable rhythms, therefore you have to provide injection epinephrine 1 milligram IV as soon as possible, and you have to continue with the CPR. Here also you have to continue with the CPR. So CPR has to be anyway given in cases of cardiac arrest, but in cases of shockable rhythms you have to immediately shock this patient. Whereas in case of non-shockable rhythm, you have to immediately provide epinephrine. Following epinephrine, these rhythms can be converted into shockable rhythms, and vice versa can also happen. See, in case of ventricular fibrillation, you can have electrical activity, something like that. This patient might worsen and he might land up into asystole as well. Similarly, a patient with asystole can convert into shockable rhythm in form of ventricular fibrillation following administration of epinephrine, and prognosis of ventricular fibrillation or pulseless ventricular tachycardia is better as compared to these non-shockable rhythms. Okay, I hope you guys got my point. But what is wrong in case of pulseless electrical activity? I did tell you guys that in these cases there can be even normal rhythms, but mechanical activity of heart will be missing. Try to understand, this defibrillator is not pacemaker. It will not restart your heart if there is no rhythm. It will only correct the rhythm if it is abnormal. So this defibrillator is not pacemaker. This will only correct abnormal rhythm. It will not start rhythm of heart, that is, it will not start electrical activity of heart. Okay, so therefore asystole is non-shockable. Whereas in case of pulseless electrical activity, you might have already normal electrical activity. What is missing over here is your mechanical activity. So mechanical support can be given with help of CPR, not with help of defibrillator. Okay, had there been abnormal rhythm in form of ventricular fibrillation or ventricular tachycardia, you could have provided the shock, but rhythm is already normal. You don't need to disturb it. See how this pulseless electrical activity can happen. Suppose someone has ruptured heart following myocardial infarction, there can be even rupture of heart. Now this ruptured heart will have no blood, so therefore pumping activity will be absent, but electrical activity will be normal. Take example of severe hypovolemia. There is no venous return. Therefore, cardiac output will also not be present, but normal electrical activity will be present. Suppose someone is having severe cardiac tamponade. Following cardiac tamponade, heart is not able to relax. And if heart is not able to relax, diastolic filling will be absent. Therefore, there will be no systole as well. So, in case of pulseless electrical activity, there are secondary causes which result into this pulselessness in spite of having normal rhythm at times. So, in this case, you have to provide high quality CPR so that pulse returns, and later on you can treat this case as per the causes. Suppose there is cardiac tamponade, you can go for pericardial aspiration. Suppose there is tension pneumothorax, it is pressing this heart. You can go for immediate needle decompression. You guys already know all these things. Right now, you can appreciate that this is ECG tracing of ventricular fibrillation, and this is ECG tracing of pulseless ventricular tachycardia, particularly monomorphic pulseless ventricular tachycardia. And in asystole, you can have flat line. This is asystole. And in pulseless electrical activity, you can have normal or even abnormal ECG tracings along with pulselessness. But these ECG tracings should not be ECG tracings of ventricular fibrillation or pulseless ventricular tachycardia. Okay, right now let's have a look at non-shockable rhythms. You can have two conditions, asystole or pulseless electrical activity. In case of asystole, you have flat line ECG, and if there is no electrical activity, it will not be followed by any mechanical activity. So there will be no cardiac output. Patient will be pulseless, and over a period of time, patient will die. Whereas in case of pulseless electrical activity, ECG can be normal. I am not saying ECG is always normal. Let's take example of normal ECG, but there will be no mechanical activity. So how you can support the heart mechanically? Therefore, provide CPR as soon as possible. No use of defibrillators in these situations, because defibrillator is not pacemaker. It cannot start the electrical activity. It can only reset abnormal electrical activity. Therefore, in these cases, you have to provide CPR to the patient, and you can use epinephrine as soon as possible. Therefore, these rhythms can be converted into shockable rhythms, and you can treat accordingly. Now you can defibrillate. In case of pulseless electrical activities, suppose this patient is having cardiac tamponade. Meanwhile, you have supported this patient with help of CPR and epinephrine. And now you figured out that this patient is having cardiac tamponade. Immediately arrange for pericardial aspiration. So in these cases, you have to treat the cause as well. Meanwhile, as per ACLS, you have to provide emergency support to this patient in form of providing high quality CPR and epinephrine. And if needed, if this rhythm converts into shockable rhythm, you have to shock this patient as well. But basic treatment will be treating the cause. Okay. Now let's study complete algorithm in detail. See, in case of ACLS, that is Advanced Cardiac Life Support, if you encounter a person in hospital who has suffered cardiac arrest, immediately start doing CPR. Provide oxygen, attach monitor for the ECG tracings, attach the pedals of defibrillator. So in case if there is shockable rhythm, provide shock immediately. Now suppose you got shockable rhythm in form of ventricular fibrillation or pulseless ventricular tachycardia, immediately provide shock to this patient. This can recorrect the rhythm of heart. Now try to understand, in case patient has not improved, you have to continue CPR and also have IV access or intraosseous access. IV access will be any day better than intraosseous access. And then if patient has not improved, provide second shock to this patient, right? And because you have got the IV line, also push epinephrine. So this epinephrine has to be repeated every 3 to 5 minutes, and this epinephrine dose will be 1 milligram IV. Okay, and now in case rhythm has not got corrected, again shock this patient. This is your third shock. Following third shock, you can conclude that this is shock resistant ventricular fibrillation or ventricular tachycardia. Now you have to provide anti-arrhythmic to this patient, and anti-arrhythmic of choice will be any day injection amiodarone. So if it is shock resistant ventricular arrhythmia, you have to provide anti-arrhythmic drugs. That is, treatment of shock resistant ventricular arrhythmia is by anti-arrhythmic drugs. Okay, because in case there is reversible cause of cardiac arrest, these anti-arrhythmic drugs will be very helpful. See, you can also have ventricular tachycardia or ventricular fibrillation due to electrolyte imbalances. You can also have these things in case of acidosis. So you have various causes of reversible cardiac arrest as well. So in case this shock is not effective, always try to provide antiarrhythmic drugs. An antiarrhythmic drug of choice over here is your amiodarone, and lidocaine is your second choice antiarrhythmic drug. Now, if patient is having asystole or pulseless electrical activity, in this case you have to provide epinephrine as soon as possible after you have already started the CPR. And in this case you have to provide epinephrine again every 3 to 5 minutes, and again the dose will be 1 milligram IV stat. And also keep on checking whether this is shockable rhythm or not. See, a non-shockable rhythm can convert into shockable, and vice versa can happen. Now here you have a statement: treat reversible causes. We have already discussed that in case of pulseless electrical activity, patient might be suffering from cardiac tamponade, patient might be suffering from tension pneumothorax. So you have to also treat the primary cause, okay, while managing the patients as per protocols provided by this ACLS guidelines, AHA 2020. Okay, so I hope now you guys got my point. This is very simple.
Begin by turning on the manual defibrillator and checking for power and readiness. Apply conductive gel or pads on the defibrillator paddles. Place the paddles firmly on the patient's chest, one on the right upper chest, the other on the left side. Visually confirm the rhythm on the monitor. Look for shockable rhythms like VF or pulseless VD. Announce clearly, "I'm clear, you're clear, everybody's clear." Charge the defibrillator to the recommended energy level. Ensure no one is touching the patient or bed. Deliver the shock by pressing both paddles simultaneously. Immediately resume chest compressions after shock delivery. Continue CPR and reassess rhythm every 2 minutes.
In case of ACLS, that is Advanced Cardiac Life Support, start giving CPR as soon as possible, provide oxygen and attach monitors to the patient for the purpose of ECG tracings. And in this case, you can figure out there can be pulseless ventricular tachycardia or ventricular fibrillation. Shock this patient. You can give 3 shocks, and in case this patient doesn't improve, you can give amiodarone as well. Plus, you can give epinephrine if you have IV line every 3 to 5 minutes. Okay. Now, in case it is a non-shockable rhythm, for example, pulseless electrical activity or asystole, here you don't need to provide the shock because it will be ineffective. Here, continue with the CPR, plus you have to give injection epinephrine 1 milligram as soon as possible, and continue monitoring of the patients, and in case you detect any primary cause, treat the cause. Okay, so now it has become very simple. So this is your manual defibrillator. We have already discussed that this is not your pacemaker. In case there is no electrical activity, it will not be effective. It will be effective only if there is abnormal electrical activity. It will reset the rhythm of heart, and restart of electrical rhythm might be normal. So this is function of manual defibrillator, helpful in case of pulseless ventricular tachycardia or ventricular fibrillation. Right, so this is your injection epinephrine, right? That is your injection adrenaline. This can be given in both cases, either in shockable rhythms or non-shockable rhythms. But in non-shockable rhythms, it has to be provided immediately. Whereas in shockable rhythms, it can be provided after giving shock and CPR. Try to understand this particular thing. And in case if it is shock resistant, ventricular tachycardia or ventricular fibrillation, you can correct this particular situation with help of drugs, that is antiarrhythmic drugs, and particularly it will be helpful in managing reversible causes of ventricular fibrillation or tachycardia. Try to understand. If you have shockable rhythms, now you guys understand what are shockable and non-shockable rhythms. Take example of pulseless ventricular tachycardia or ventricular fibrillation. Provide CPR to this patient, shock this patient. If you have already given 3 times shock, you can go for amiodarone or lidocaine. What about use of epinephrine? Use of epinephrine every 3 to 5 minutes can be done. Suppose your patient doesn't improve after providing shock, you can give injection epinephrine every 3 to 5 minutes, right? 1 milligram IV. This, and this will increase the perfusion of heart. And you guys already know that ventricular fibrillation and ventricular tachycardia can occur following ischemia of cardiac muscles. Ischemic tissue is hyperexcitable. So if you happen to give epinephrine to these patients, cardiac ischemia might improve because it will increase the perfusion of heart, and ventricular fibrillation and ventricular tachycardia can resolve. Whereas amiodarone, this drug is given in shock resistant ventricular fibrillation or ventricular tachycardia, and this is particularly important in treating cases of reversible cardiac arrest. Try to understand this particular point. Whereas in case of non-shockable rhythms, what are your non-shockable rhythms? Non-shockable rhythms are pulseless electrical activity and asystole. In these cases, you don't need to shock this patient, provide CPR, and now you have to provide injection epinephrine as soon as possible. ASAP. Again, the dose will be 1 milligram. I hope you guys got my point. And dose of this amiodarone is 300 milligram stat, followed by 150 milligram later on. As per AHA guidelines 2020, following these ACLS steps, you have to ensure whether your resuscitation is in right direction or not. See, in case of cardiac arrest, we have been studying that your patient is pulseless, and because this patient is pulseless, perfusion of all the organs has decreased or stopped at all. Therefore, now blood will not be able to extract carbon dioxide from tissues and provide it to the lungs for the exhalation. In case of cardiac arrest, CO2 exhalation will be zero because there is no circulation. But following resuscitation, as per ACLS guidelines, perfusion will again improve. Suppose you started providing CPR, perfusion will improve, therefore blood will reach your organs, and therefore blood will pick this carbon dioxide and provide this to lungs, and now lungs will exhale this carbon dioxide. So in expiratory air, if there is proper resuscitation, carbon dioxide will increase. Try to appreciate this simple thing. And in our discussion on ABG, we did discuss that partial pressure of carbon dioxide in blood is in the range of 35 to 45 millimeters of mercury. Same applies here also. Partial pressure of carbon dioxide in exhaled air is in the range of 35 to 45 millimeters of mercury. So in case of proper resuscitation, again carbon dioxide will be present in exhaled air in the range of 35 to 45, and this EtCO2 monitor can pick up these values. This EtCO2 sensor is applied in the expiratory limb of ventilator, and this EtCO2 will figure out whether this carbon dioxide in the exhaled air is normal or not. So as per AHA guidelines 2020, you have to also do EtCO2 monitoring to figure out whether your resuscitation is effective or not. Suppose in case of exhaled air, you have 0 millimeters of carbon dioxide partial pressure. It means that there is no proper perfusion, and because of no proper perfusion, carbon dioxide is not returning back via blood to the lungs, and therefore it is not being exhaled out as well. Whereas if this carbon dioxide in the exhaled air is in the range of 35 to 45, it means that again you are able to reperfuse the organs, and now as the circulation has improved, carbon dioxide is being returned to the lungs, and now the lung is able to exhale this carbon dioxide. Okay, so as per this discussion on EtCO2, I am trying to tell you guys that EtCO2 monitoring has been mentioned as per AHA guidelines 2020. This EtCO2 will detect carbon dioxide in exhaled air. It will represent proper perfusion of tissues following resuscitation, because this CO2 will be present in exhaled air only if perfusion has been corrected. Okay.
Start by turning on the capnograph and ensuring proper calibration. Attach the sampling line to the ET tube or airway adapter. Ensure the patient is ventilated adequately for accurate readings. Observe the waveform pattern on the monitor. A normal capnogram has a square shape. Note the numerical value of EtCO2, typically 35 to 45 millimeters of mercury in a healthy adult. Monitor changes in waveform and value for signs of hypoventilation or hyperventilation. Flatline waveform may indicate disconnection, apnea, or cardiac arrest. Use EtCO2 trend to assess CPR effectiveness. A spike post-ROSC is a good sign.
Right now, let's discuss very important part of ACLS, that is identifying reversible causes of cardiac arrest. And you can memorize all these things with help of 5H and 5Ts. In case of pulseless electrical activity, we have already discussed cardiac tamponade. In case of pulseless electrical activity due to cardiac tamponade, you can continue with your CPR, provide epinephrine to this patient, and when you have figured out that this patient is having cardiac tamponade, go for pericardial aspiration, and this will help in complete recovery of your patient. So if you keep in mind these reversible causes, you will be able to treat the patient of cardiac arrest more effectively. Try to understand, you have shockable rhythms and you have non-shockable rhythms. Even in shockable rhythms in which you have better prognosis in form of ventricular tachycardia or ventricular fibrillation, sometimes you can have shock resistant ventricular arrhythmia. We have discussed that in spite of giving 3 shocks, patient might not improve. So in case of shock resistant ventricular fibrillation or ventricular tachycardia, you have to provide antiarrhythmic drugs, and these antiarrhythmic drugs are amiodarone and lidocaine. Now try to understand, these reversible causes can be corrected with help of amiodarone. On the other hand, in case of non-shockable rhythms, you have toxins, tamponade, thrombosis, pulmonary embolism, or tension pneumothorax. These cannot be shocked. And on the other hand, you cannot treat this case with help of CPR or epinephrine. You have to treat the primary cause as well. So you have reversible causes of cardiac arrest on both the limbs, whether it is shockable rhythm or non-shockable rhythm. If it is shockable rhythms, amiodarone will do wonders, right? Not the shock. And if it is non-shockable rhythm, figure out what is the cause and treat accordingly. Even here, amiodarone will make the patient survive, and over a period of time you can figure out whether there is severe acidosis or hypoxia or hypovolemia, and then you have to treat accordingly. Now crux of the discussion is that on one hand you have shockable rhythms, on the other hand you have non-shockable rhythms. These shockable rhythms can be shock resistant, and causes of shock resistant ventricular fibrillation or ventricular tachycardia can be these, and these can be managed by giving amiodarone and later on treating the cause. In the same way, in non-shockable rhythms, you have 5 Ts, and patient with these 5 Ts can be supported in ACLS by CPR and epinephrine. And whenever you happen to figure out the cause, treat immediately the cause. Okay. Right, now let's discuss complete chain of survival following cardiac arrest. It can be out of hospital cardiac arrest or it can be inside hospital cardiac arrest. And you have 6 components in this chain of survival. And this 6th component has been recently added as per AHA guidelines 2020. And this is related to neuroprognostication. Right, now let's discuss post cardiac arrest care algorithm. Suppose patient had cardiac arrest, and as per ACLS guidelines, you resuscitated this patient and your resuscitation was successful. There is return of spontaneous circulation. Try to understand, patient had cardiac arrest, and following cardiac arrest, you had successfully resuscitated this patient, and following successful resuscitation, there will be return of spontaneous circulation. Spontaneous circulation, popularly known as ROSC. Even after return of spontaneous circulation, patient might be comatose or patient might be having normal neuronal activity as well. In case your patient is still comatose, you have to figure out what is present status of neuronal activity and you have to manage this patient accordingly. So following resuscitation, you have post cardiac arrest algorithm, and if there is successful resuscitation, that is return of spontaneous circulation, now you have to provide post cardiac arrest care. And sixth point as per chain of survival is your recovery. In this recovery, we have already discussed that you have to study and treat the neurological condition of brain, and this particular thing is related to neuroprognostication. Try to understand few things over here. Here you can appreciate TTM, ECG, CT, MRI, etc. So this is to understand the present neurological status of this person, and you have to manage this patient accordingly. This TTM is targeted temperature management in form of therapeutic hypothermia. Let's discuss. Suppose you have successfully resuscitated a patient following cardiac arrest, and now there is return of spontaneous circulation. Even after return of spontaneous circulation, neurological status of patient might not be normal. Your patient might still be comatose. Therefore, you have to evaluate the neurological status of this patient after return of spontaneous circulation, and this is known as multimodal neuroprognostication. Okay, and in this case, you have to figure out the current neurological status of patient by going for head CT or MRI. You can also go for EEG, and you can also look for certain biochemical parameters which will tell you about neuronal damage. In recovery phase, you have to do neuroprognostication, and this can be done with help of imaging, with help of EEG, with help of biomarkers. Try to understand. First, let's talk about imaging again. If you are evaluating within 24 hours, go for CT head. Right, in evaluation later to 24 hours, you will go for MRI brain, you will go for EEG, you will go for biomarkers related to neuronal damage. Okay, now in EEG you will look for somatosensory evoked potentials. That is, if you stimulate any peripheral nerve, stimulus will reach brain, and now brain activity will be recorded. This is known as somatosensory evoked potentials. Okay, and you can also look for certain biomarkers which can indicate neuronal damage. For example, neuron specific enolase. This is your neuron specific enolase. So these things has to be evaluated as a part of neuroprognostication. Right, now let's study algorithm provided by AHA for pediatric cardiac arrest. See, everything is almost same as we have studied in adults, but there will be some differences. You guys already know that respiratory rate is more in infants and children. Therefore, if you happen to provide CPR to this patient, the ratio of chest compressions versus rescue breaths should be in the ratio of 15 is to 2, not 30 is to 2. Try to understand. When you do cardiopulmonary resuscitation in adults, you follow 30 is to 2, that is 30 chest compressions versus 2 rescue breaths. Whereas same thing, same CPR in case of pediatrics, it will not be applicable. There will be 15 is to 2, that is 15 chest compressions versus 2 rescue breaths. Or if there is advanced airway, suppose you have intubated your patient, then you have to provide these rescue breaths every 2 to 3 seconds. That is, if you have advanced airway. Advanced airway means that you have intubated this patient. If you have intubated this patient, always try to provide rescue breath every 2 to 3 seconds. Therefore, your respiratory rate will be approximately 20 to 30 per minute. And you guys know that respiratory rate of children is more as compared to adults. Okay, so these are significant changes in case of pediatric ACLS following cardiac arrest. Right, in similar way, you have ACLS guidelines for cardiac arrest in pregnancy as well. So as per AHA guidelines 2020, you can perform perimortem cesarean delivery in case there is no return of spontaneous circulation in 5 minutes. Earlier, as per previous guidelines, it was 4 minutes. And AHA has also enumerated the causes which can lead to cardiac arrest during pregnancy. Okay, right. Last but not the least, let's also discuss in brief about adult bradycardia algorithm as per Advanced Cardiac Life Support. So you have bradycardia algorithm as well. Try to understand. If patient has asymptomatic bradycardia, you have to do nothing. Okay, in case your patient is symptomatic, drug of choice should be atropine followed by dopamine or epinephrine. So here drug of choice should be your atropine. We have already discussed in case of ACLS post cardiac arrest, you have to provide epinephrine in dose of 1 milligram, and it can be repeated 3 times. Same applies for atropine as well in case of bradycardia. If it is symptomatic, you have to provide 1 milligram of atropine, and you can repeat it 3 times. Maximum 3 milligram can be given. This is your atropine 1 milligram IV stat has to be given, and it can be repeated thrice. So maximum amount which has to be given is your 3 milligram, and this is almost similar to the dose of epinephrine. So we have studied complete ACLS guidelines as per AHA 2020. That's all for today. Bye bye.